This is Mazianonte and his Atlantic superstar band of Umofia. Wait. Someone is first on me. Someone is first on me. Who is that? Ooh, that is Dr. Damages, my son. Maybe he's going to give, hold on, maybe he's going to give me some money. My son. Hey, Pops, just a quick one. Have you taken your COVID vaccine? No. Why? Why not? I still have some questions. What questions? Is the vaccine safe? How many times do I have to tell you? I took it, your president took it, even your Pope took it. As far as we in the medical field know, it is safe. As far as, so you are not 100% sure? Of course, we are sure. Just not 100% sure. You see, unlike religion, in science, we are not always 100% sure about anything. So, what other question do you have? Will I stop wearing mask and washing my hand 100 times a day if I get the vaccine? Will I be free to travel again and visit my grandchildren and hug them? Will everything get back to normal? Will kids get back to school and my priest go back to giving me communion on Sundays? I miss the wine. No, Pops, no. Until everyone or enough people are vaccinated, we have to follow these guidelines for our own sake. If I get the vaccine, will I be resistant to COVID-19? No, not totally. But if you should get it, you have a better chance of surviving it. Will this one shot be enough, or would I be required again to get more? No, for now, depending on the vaccine you get, a full dose of 1 or 2 will be enough. But if doctors determine in the future that they are not enough, you can get a booster shot. Okay. One last question. Now, if something happens to me after getting vaccinated, will the vaccine maker or the government pay liability to me or my children? Not you, my children, the other children. Nothing will happen to you, Pops. Nothing will happen to you. The government and the drug makers are protected from any liability because it is an experimental drug approved on an emergency basis, So why again should I get the vaccine if it doesn't guarantee anything? It doesn't? Is that all you took away from this our conversation? You know what? Let's try something different. What? Do you say your morning prayers every day? Of course, yes. The evening prayers and the night prayers. I say my rosary every day. I never fail. Wow. Remind me again, what are they for? For God's protection, of course. Against what? Against the devil, against witches and wizardries, against my village people and the juju priests, against the killer headsmen, against Buhari, and against all powers and principalities. Pops. What are your prayers for? This boy, Come on. You have stayed too long in America. Haba, have you joined the Illuminati? I'm not laughing. Do you do prayers? Protect you from bad things? Every day. Good. So because you pray, no bad thing has ever happened to you? Yes, no, unless God wants it to happen. Let me say this again. Have prayers made your life go the way you wanted it to go all the time? Yes, no, unless God doesn't want something to go the way I want. So, do you have worries in life? Any? No. Mazianonte. Hello? I'm your son, remember? Dr. Damages. So let me ask you again. Despite your constant prayers, do you have any worries in life? Okay, yes. Why worry if you pray? What? Everyone worries about something. Yes, why worry if you pray? I don't understand what you are saying. Okay, let me put it in another way, Mazianonte. Why pray if you worry? This boy, you are giving me a headache again. Pops, go and get your COVID-19 vaccine. Will it make this headache go away? Yes, yes, with a bit of prayer too. All right, I will go. Preventative Medicine is brought to you by Open Society Initiative for West Africa, OSIWA. Side of the pandemic that will live to tell the stories. Coronavirus is so stubborn that we need to remain cautious and vigilant. In the meantime, wash your hands, wear your mask, maintain social distance, follow health officials' guidelines, and stay safe. It is only those who made it alive on the other side of the pandemic that will live to tell the stories. So, Mazianunti, you're in America now. Come on, go and get your vaccine. It's safe. Come on. Dr. Damages, you want to bet? Bet with me? What bet? If you win, I go and take the vaccine. If you don't win, I won't take COVID vaccine. I can't to play what? Penalty? 5 penalty in the snow? No, Mazianunti. No, we can't do this. That's it. That's the only condition. You know what? Udoka, throw that ball to me. Throw me that ball. You want to go outside? That's what you want? Okay, let's go. You want to put 5 penalties. You ready? Let's go. Ready? Oh, after exercise. All right, take it. Mazianunte, it's coming. It's coming. I'm here. After this one, and after this one, and after this one, and Right. It's a go! Yes! I don't want.
Hey Jacob. Hi Trish, how are you? I'm good. So are you gonna open the door for me or what?
What about your face mask?
But I'm your girlfriend.
You need a face mask before you come in here.
What? Seriously, Jake? I can't deal with this. I can't deal with this. What do you mean? Face mask? I can't deal with this. Am I not your girlfriend? Why should I need a face mask to come in here? What's going on, Jake? What's going on? I can't deal with this. Seriously? Open the door this minute.
Coronavirus is so stubborn that we need to remain cautious. In the meantime, wear your mask, wash your hands, maintain social distance, follow health officials' guidelines, and stay safe. Only those who made it alive on the other side of the pandemic will get a chance to tell the stories.
All right.
Thank you so much. I want to thank all our panelists for this part one. I want to thank Dr. Liu. Thank you so much for joining us and being very kind with your time. And Dr. Mukhtar, thank you so much for joining us and being kind with your time and taking the questions. Also, Professor Nwosu, thank you so much for joining us. And Dr. Ndibe, I appreciate your time. We're now going to go to the second panel. Initially, I planned that we have a break, but we don't have time. I know that there are people who still have questions like Kayode and Michael Buefi, but I will please plead with you so that we go to part two. There are people, some of our guests, they have to go, and we want to get them to participate, and then you can ask your question too. And of course, some of these are guests, the people that are in the panel will stay by and stand by and also be able to answer your questions. So without wasting much time, let me introduce my co-host for the second part. And he is a physician and a research scientist in New York, Dr. Chisom Okezue. Chisom, welcome.
Hi, everyone. Good afternoon. I'm nice to be able to join this. I'm actually at work, but Rudolf wanted me to join, so I had to ask for a little bit of break. But it's always nice to be a part of conversations about Israeli healthcare in Nigeria. Can you all hear me?
Yeah, we can hear you. We can hear you. So we start this segment by getting somebody who survived COVID to tell his story for 5 minutes. Now, we had 3 people lined up, but we trimmed it down to 1 person because of time. So Austin Okwesile, welcome to the show.
Thank you, Rudolf, for having me. Can you hear me?
Yeah, we can hear you.
Okay. Well, I had a very terrible experience with COVID, and that was 2020, sometime around the middle of May. I started this weird sensation on my laps. It was very painful sensation. I didn't know what it was, and so I decided to go and see my doctor. I got to the doctor was able to figure it out, and he sent me for a CT scan. So I went for the CT scan. 3 days after the result came out, there was nothing. So I suggested to the doctor, that I would like to go and, take the COVID test. So I went there that very day and found out that I was positive. My God, that was, my world crashed that very day, because I was thinking, in my mind, how am I going to be able to isolate myself from my kids and my family? That was the initial thought I was having. I kept on asking the lady, am I going to make it? Am I going to survive this? The lady was like, she doesn't know what's going to happen. It's 50-50. So I went home. I told my wife, what's going on, that I was tested positive. Immediately we started the local therapy, the African therapy that everybody was doing. That is garlic, ginger, and inhalation of steam and stuff like that. And I think that was really what really helped me at the initial stage. So I was home for 14 days, and within these 14 days, a lot of strange experiences that I have never witnessed in my life, my entire life. My back was hurting, my temperature was like 104. I was sweating, very tired, couldn't get up from the bed. I kept on lying down, looking for a place to lie down. And thank God for the special grace of my wife, who, she kept on, trying to get me up, try to walk around and stuff like that, push me into the bathroom, try to provide, food. I wasn't able to eat anything because by this time I already lost the sense of taste and sense of smell. But I wasn't coughing. Strangely, I was not coughing. So After the 14 days, I was so happy. I was elated. I was like, okay, thank God I survived this thing. You know, I think if COVID is gonna kill you, it's gonna kill you within 14 days, because it was really bad for me, especially for the fact that I have some, underlying, conditions also. So I was like, okay, I survived it. Thank God. I was so happy. So, but then after 3 days, that's on the 17th day, in the middle of the night, I wasn't able to breathe. Very scary. I was having pains on the lungs. If I tried to breathe, so this time, it's like I was having shortness of breath. I wasn't able to breathe at all. So I called my wife immediately. I said, hey, we gotta go, man. I'm having problem breathing. And we jumped into the car, went to Bowie Health Center, and they did the CT scan. They were able to see the fibrosis on my lungs. So the doctor advised me that they're gonna take me to the COVID center. Initially, I objected. I said, no, I'm not going to any COVID center. I think it's better for my wife to take care of me at home instead of going to, any COVID center. Because when you look at the, on the television, you see what is going on. Once they push you into the ICU and everybody is gone, I said, no, I'm not going to any COVID center. I said, I think I'll go home, just write the medications for me. So the doctor told me, hey, man, you have blood clots. So you don't have that chances. As a matter of fact, we are taking you right now to the COVID center. As we are speaking, the ambulance already came. I didn't have any option than to, jump into the ambulance because of that blood clot that, he had mentioned. So they took me to the COVID center at the Laurel Regional. And once we got there, they took me in and they said I should wave bye-bye to my wife. I'm like, wow, this is getting serious right now. So my wife left and they took me, started me on heparin. As at that time, there was no medication anyway. They started me on heparin and Tylenol and what again? I think I was dehydrated also, so we were giving me fluid also. So 3 days on my admission at the hospital, initially I wasn't coughing, but after 3 days at the hospital, I started coughing. I can cough for at least 1 minute without stopping, non-stopping, 1 minute. They provided the incentive spirometer. I was not even able to bring it up to 2. I kept on trying to blow it. The more you try to blow it, the more, I was coughing. So it was still stuck on that yellow stuff. I was like, damn, this is serious. How am I gonna come out of this? But the good thing is that luckily I was never intubated. I kept on telling myself, I can breathe, I can breathe, I can breathe. So I was not intubated. So on the 4th day, the doctor called and as we were speaking, there was nobody in the hospital. The doctors, they were already gone. You can only see the nurses around. The doctor called every morning on video and talk to you to know how you feel it. So I kept telling the doctor, I think it's better for me to go home because over here I'm not able to eat. And nobody cares if you are eating. Nobody comes to check on you. Everybody was gone. Once you are in there, they just come once in a while and peep. And I was not even connected to any monitor as at that point in time. So the doctor was telling me, oh no, you still have to be here. We are still monitoring you. I said, hey man, I'm not seeing anybody monitoring anything. Nobody's monitoring me. It's better for me to go home. My wife will take better care of me at home. So I kept on insisting. So the doctor said, okay, calm down. I told the doctor, look, I'm a healthcare worker also. No, he said, okay, let's see what we're gonna do for you on Monday. So on Monday, I was discharged. So I went home. I kept on doing the local therapy that we are doing, the ginger, garlic, and the steam inhalation. And believe me, I think that was what really helped me. That was what really helped me. And by the special grace of God, I survived it. But then after 3 days again, when I went home after 3 days again, the same episode repeated itself again. I was not able to breathe again, So I went back to the hospital again. At this point in time, the doctor said, hey, I think actually the fibrosis is less than what it was in the beginning. I think this time around, you can, go home and just manage the pain with pain medications. So finally, I was prescribed. I had the option to use Coumadin, warfarin, or Eliquis. But the only thing is that with Coumadin, you have to go for tests at every interval to check the therapy level. But I didn't use that, and I told them to give me Eliquis. The Eliquis is very expensive. For a month, it was costing me $500 because I had to pay out of pocket at this time. Luckily, I sought for insurance coverage, and so the government was giving us at that point in time. So they approved me for the insurance coverage. The hospital bill came, this is, and to the tune of $10,000.
Okay.
Within that week that I was there.
Asano, round up. This is a wonderful story, but I know we're out of time. Can you please? We have other.
Sure. But the strange thing is, up to today, I'm still having the effect of COVID. I'm still having those pains. Once in a while, those pains comes. That's one strange thing about this thing. My life has not been the same since I had that experience. I'm still managing pains, but I thank God that I survived it. Thank you, Rudolf.
All right, thank you so much. I didn't inform people that Austin Okwesile is in America. We had two people who will have joined us from Nigeria who also suffered from COVID. Our goal is to compare, to see the difference in terms of how they are treated in Nigeria and how people who are patients here are treated. But we have to move on. I think by the time he talked about ambulance coming to pick him up, we basically know he's in America. All right, Dr. Chisom, you're next.
Yes, okay. So I'll go ahead and introduce Dr. Ngozi Obiwanne, who is a clinical research professional from Dallas, Texas. She will speak on medical research gaps and how to fill them for optimal healthcare delivery. Dr. Obiwanne.
Yes, I actually would say I wish the government officials were still available because this is actually of a big concern to Nigeria. Now, when we talk about the medical research gaps in Nigeria, most of the questions that were being asked during the first phase was with regards to this issue. So I actually broke it down into different sections. So to make it put it in a very expedient manner. Number one, the issue we have is the human resources. So the way Nigeria is structured and the things we know that are going on in the country as we speak, and we are losing quite a bit of our medical professionals, and not just doctors, even our nurses. And now with the limited number we have, and we need to ask ourselves, those that actually trained to be, because not every doctor is experienced in research. So they're how prepared are our doctors and our nurses to actually, participate in research. Now we talk about issues concerning the general conditions. How do we capture our data? Data capture. How many hospitals can we attest to their data system, how they capture the data of every patient who is actually a potential subject in a clinical trial? Because it's when we start with conducting our own medical research, then we can actually come up with solutions that are in tune to our own demographics. Because like it or not, there was something Professor also said, is how are we, the immunogenicity of the medication, how are we testing in regards to our own population back home in Africa? Because whether we like it or not, something happened in Africa, something happened in Nigeria with regards to COVID. The effect that was expected was not what was seen. The rate of mortality rate that was expected was not what was seen. So the question is, what is that? What's that special factor? Have we tried to look into what it is? Is it our environment? Does it have anything to do with our diet? Or what is it? So these are questions we should ask. Well, how do we come to that point? We need data. But this is the limitations. This is part of the limitations we have, which when we talk about this, we're talking about the infrastructures that are not available. We talk about the institutions, how equipped they are, and how then we talk about that. Of course, the human resources are part of it. And we talk about our social cultural, the effect of our culture, the local, our traditions. We know that some of our people, like in the West, they believe in so much in the local herbs, the what we call abo and all that, the social organization, the religion, the politics. How does it affect us? These are things that bring forward the gaps in research. What are the religious aspects? How do people relate with new condition? Let's say there's a new pandemic, now monkeypox is coming. What are they thinking of? Where is their mind? Their thought process? Where is it? So these are part of the gaps. This is another section that actually puts forward the gap we see in the medical research. Now we go down to logistics. Now, for logistics, we're looking at the local import and export policies. Now, for our importation policies, what do they look like? The cold chain shipment, how is it? I asked I wish Dr. Mukhtar was here, because my question was with regards to the vaccine that is received. How is it maintained? This is the cold chain. How is it transported to the rural areas? Now, how is it maintained at the rural areas? How are the temperature monitored? Is it viable? Finally, we ask people to take vaccines. So how do we know that what they're taking is viable? So these are questions. These are things that are issues, real issues that we cannot dance over. So we also have the institutions, the limitations with the institutions, and it still goes on to the general conditions with infrastructure, the illiteracy. Now go down to the educational barrier, the illiteracy. How do we pass this message to our people? How do they receive it? And how also do they, definitely we need feedback. How do we relate? How do we communicate with the people, mostly in the rural areas? When we have not covered, the rural areas, we did not say we are doing well in the healthcare sector, I must say. And so we have a lot of work to do. That's why sometimes I doubt the data that is coming out of some of the publications. I kind of doubt it, and because I still ask the question: how do we relate with this? What's the data? Where is it coming from? Then the last point for me will be perception of cohesion or exploitation. How are the people? It still has to do with the literacy and the illiteracy and the illiteracy that's obtained in the society. How do they receive the message of vaccines? How are we educating the masses in the rural areas? I still insist, the rural areas. How do we communicate? How do we let them know what needs to be done and what should not be done? How do we, we talk about the hand washing teaching that was going on? How many of the rural centers were actually all the preventive process? How many of the rural centers benefited from all this? And we do not know. And also, we know that there are issues with in that we have some unique things in Nigeria where we have we've seen cases that we have fake vaccination cards, and people don't actually run the tests. So we ask ourselves the question: how do we checkmate all this? And how, for those vaccines that are being taken, how do we also, how do we research and know the efficacy amongst our people? Because we are actually different. Our demographics are different. How are we just taking everything hook, line, and sinker from the West and putting it on our people? Like now, when the question in regards to J&J vaccine, and I know that Dr. Mukhtar mentioned that it was a small number. No, that from the recent FDA update, it is 1 in 100,000 doses administered. That does so. That's 1 in 100,000 case for 100,000 doses administered. So that's quite a bit. So how are we checkmating all this? How are we screening for the risk factors, potential risk factors in this demographics? Because as we know, we have more of the young population. And since we're pushing the J&J vaccine to the rural areas, we have those populations more in the rural areas. So how are we checkmating to know that they are we are actually searching for the right stuff and also putting out the right message there and giving what is required? Because if we know that, okay, we look at the risk factors for thrombocytopenia, we know that, okay, this is applicable. Do we offer another vaccine in place of that? These were the questions I was expecting him to answer, but that weren't answered. So for us to have an optimal healthcare delivery in Nigeria, we need to address all this. And the fact is that it still boils down to governance. That is a fact, because we still need that conducive environment. We still need that conducive environment to make sure that we actually deliver an optimal healthcare system for the Nigerians and the Nigerian public. So that is what I think the government should actually focus on, because now once all this is put in place, it would also attract clinical research and opportunities in Nigeria. And here in the United States, there are still some studies. Some of the pharmaceuticals still have some global studies, and it's not just studies in the United States. You can be on a study as a global study. You have study sites, and they have sites in India and all in Asia, in the Pacific. They have in Europe, and even some Africa, like South Africa. Yes, but it's sometimes it says that the data coming out of Nigeria is questionable. So somehow it's not. It's conducting a research, of extensive of that extent. It's not really viable. They will question the data that's coming out from there. So, and also the subject safety. So our government should actually. I know that I wish everything was a bit diversified, where the government doesn't have a monopoly of a lot of things. Otherwise, I know the private sector will want to come in and individuals, but it still boils down to government. That's what I must say. And good governance, creating that enabling environment for actually the healthcare sector to thrive. And then the private sectors, because some of the sites, they are not owned by government, they're owned by individuals. So this is just what it is. And I must rest my case here. I will not go on. Thank you, everyone.
All right. Thank you, Dr. Mbazuluwane, for that rich presentation. I know that the government officials are not here currently, but we are going to keep this conversation going, and they are going to watch this, and we're going to keep in touch with them. But let me go to the next presenter. Ronsi Chidebe. Ronsi is the Executive Director of Project Pink Blue. He will speak on the role of the NGO in care delivery and awareness during a pandemic. Mr. Chidebe, welcome to the show.
Thank you very, very much. Thanks, Rudolf, for this great opportunity. I really appreciate it. I would start by saying that, coronavirus is here to teach us a lesson, actually. But I really thought that we learned in Nigeria, but I think it's still arguable. If you listen to all the speakers here, you'll definitely know it's still arguable. Nigerians' healthcare is still really unhealthy. That is the truth. But my only concern is that instead of fixing it, our rulers and our leaders are still busy flying up and down to benefit from other countries' productive healthcare system. So this is really the painful reality. I mean, the Presidential Task Force or Presidential Steering Committee on COVID-19 did a fantastic work in controlling the pandemic at that time. However, the question has always been, are we sustaining this progress? All the epidemiologists that were trained and all the doctors that were trained, are they still in Nigeria? So this is where the role of NGO is so important, and not just in our awareness, but also in advocacy. I remember during the COVID-19, one of the things that we did in my organization, Project Pink Blue, that we're focused in cancer awareness, is to release a very strong worded press statement urging the federal government to prioritize cancer patients in COVID-19 vaccination. Because we realized that most people who are really having access to these vaccines were, people who are very close to the high-end people. And let's not forget that the first patient of COVID-19 that died in Nigeria was a cancer patient. So as an NGO, we pulled that advocacy and said federal government must make conscious effort to protect cancer patients. And I think many other NGOs across the country did a fantastic and phenomenal work in creating awareness, reaching rural communities, in bringing all sort of intervention. Mental health in Nigeria is something that is rarely discussed. People are just more interested in giving people drugs. Sometimes people are just depressed. People are really anxious. People are feeling down, that they really need mental health support, but very little is being done in this regard. But I can tell you that during COVID-19 and even post-COVID-19, we saw many nonprofits really doing a lot of work in this area, which is really phenomenal. I just wanted to really sort of, bring this conversation to what we have learned from the perspective of the NGO, what needs to be done, trying to look from post-COVID and in preparation for another pandemic. We don't know when another COVID or another pandemic will come. So number one, I would say global health is truly not global. I really enjoyed, the questions from Professor Okonkwo, and I must really commend him. And when you hear him speak, he's speaking. He represents the demographic that I belong to, right? And Prof, thanks for your presentation. I really enjoyed it. So my assertion now comes to the level of global health is truly not global. If you think about it, global leaders are more interested in what happens around them. Painfully, you see the Nigerian government leaders, more importantly, tilting to what really happens, what the global leaders say, instead of thinking of what the people say. Let's look at this from an example. Lassa fever was discovered in 1969 in a town known as Lassa in Borno State. Lassa fever, every single year, there is always one outbreak of Lassa fever, not just in Nigeria, in Ghana, Guinea, and in many parts of West Africa. Despite this outbreak, there is still no Lassa fever vaccine. Over 300,000 people cases of Lassa fever is actually announced every year, and over 5,000 people die. So the question now is, COVID-19 came, and in less than 2 years, we have a vaccine for it. This particular Lassa fever has been killing a lot of people in West Africa for several years, and no one has gotten a vaccine for it. That is to tell you that the global leaders are interested in themselves. The pain or the anger is that the African leaders, the African governments are not interested in protecting Africans. So they don't even listen to the healthcare of Africa. They are just more interested in where the world trade is. That is where they want to go. So this is one major thing we have to really what we've really learned from COVID-19. I need to ask ourselves a very bold question on where is Africa going? Number two, sustain the achievement from the pandemic and strengthen the healthcare. The reality is that 60% of healthcare service, in this country is actually provided by private sector, and just 40 is probably by government. At the moment, there's no universal health coverage. 5% of Nigerians are only covered by health insurance. Interestingly, I saw in the comment section when someone was saying that there is a need to increase health budget. But I will shock you. A few days ago, I was speaking at an event hosted by the World Bank Farmer Access Foundation. We're talking about health financing dialogue. And the director of budget planning mentioned that the Ministry of Health returned some money from the previous year's budget. Who does that? And we all are here shouting that that the federal government, for instance, in 2020, the federal government budgeted less than 2,000 naira, that is 4.2 pounds for the healthcare of each Nigerian. And we have healthcare leaders that are returning money, So I think there is a need for us to really look at this problem of competence in healthcare. The people we have given our healthcare to manage does not have the capacity. So this is what we need to learn. This is one question we need to ask ourselves going forward, post-COVID. Increasing healthcare budget is great, but let's compare that with the competence of the people who are managing and people who can account for the existing budget. It is a shame, actually. It's really a big shame. I mean, it's still arguable who the current Minister of Health, Minister of State for Health, who he is, his experience in healthcare. The current Minister of State for Health, his experience in healthcare. I doubt if he's a doctor, a nurse, or probably a healthcare advocate. I doubt if he has ever done anything like that. So when you put the wrong people in a place where they don't have any experience in, what do you expect to get? So while we're thinking about post-COVID, we should think about some of the structural things that Professor Nwosu asked as a question. And I'm not sure he got the answers he needed. I also wanted to talk about the next thing I want us to think about is wrong perception of healthcare. And I'll tell you, because I am a health advocate in Nigeria here, the perception of the healthcare leaders and policymakers in Nigeria is that healthcare is an expenditure, it's like spending. While in other part of the world, healthcare is investment. When you budget for healthcare, you are investing, right? You see the kind of money they pump in all different sectors. But in healthcare, another thing we need to think about, health workforce. Our healthcare workforce is like really, really going low every single day. What are we doing? A previous minister mentioned that doctors should actually think about being farmers. And, you also ask yourself, where are we picking these people from? Is there anything in Abuja that once you move from wherever you are, you get to Abuja, that your brain turned upside down, that you don't think properly anymore? Because these are professors that we looked up to. But once they get to that sphere of power, they begin to think as if like their brain were all wiped out. This is one serious issue we must really discuss. We must question ourselves, what do we want for the healthcare workforce of Nigeria? And believe me, if you bring all the whole best machine from all over the world to Nigeria without the workforce, it's zero. My next suggestion again will be, we need a law to restrict public servants from seeking healthcare abroad. That is it. We need to push this. In 2017 alone, President Muhammadu Buhari spent, 2017 alone, 103 days in London, receiving medical treatments, spending taxpayers' money, thousands of, pounds. In that same time, over 3,000 women died of breast cancer. Over 2,000 men died of prostate cancer, according to WHO, right? After the pandemic, we all assumed and thought that, things are going to change. But immediately the lockdown were all open, governors, himself, senators, and everyone are jumping to the US, to the UK, and all the rest of them. If we're not ready to have a conversation about medical tourism, especially among the public servants, then we're really not ready to really move forward post-COVID, or we're not even prepared for any other pandemic that is coming. My next suggestion again, or my next trigger again, is vaccine and volume. Dr. Aliyu, very brilliant presentation. He talked so much about vaccine uptake. But let's face the reality. Today, we're talking about vaccine availability in Nigeria. The problem is not availability. The core problem with vaccine is the volume of vaccine needed in Nigeria. I'll give you an instance. Over 50 million women and girls are at risk of human papillomavirus vaccine. So these over 50 million women need human papillomavirus vaccine in Nigeria to prevent cervical cancer and other sort of disease that the HPV could cause. But do you know that the 15 million doses that these women need in Nigeria can actually be sufficient for about 4 to 3 countries in Europe? Do you think Nigeria have the capacity to pay these pharma companies for them to forget about Europe that could pay the money and bring it down to Nigeria? And the government is not even thinking of how can we produce this vaccine in Nigeria. So these are the real issues in preparing for the next pandemic. Our volume, our population is explosive, is exploding every single day. And you can't manage this kind of population without building a sustainable healthcare. All we're talking about is vaccine uptake. The Nigerians are not taking up vaccine. You don't even have the system to even ensure that people can take this vaccine. People don't have, there's no system, that's the truth. All these things you hear about Nigerians take the vaccine, there is nobody educating Nigerians on what this vaccine should be. You need to educate people, you need to build a system that helps people to trust you. A healthcare system that is not trusted by the president. Who am I as a local citizen to trust that healthcare and take a vaccine from them? Well, I'll just put in very quickly some short suggestions. Number one is check health corruption. We must check health corruption. We know it exists. Number two, e-government. Till today, do you know there are still so many federal government staff that are still at home because there are no laptop for them to work? So they were asked during COVID, go home till today, and they're still receiving salary. Why are we always not thinking about innovatively on how to get ourselves like an electronic country? Number three is Nigeria must begin to produce its own vaccine, as I said. Our healthcare leaders must begin to serve the people instead of their principals. That is all we'll see. People just come on Zoom meetings and come to meetings to defend their principles, to defend people who pay them and not to defend the people. Health budgeting should be seen as an investment and not just an expenditure. Fund PhD, that is the next solution. Fund PhD. We can't be talking about generating data in Africa and people in Nigeria have to struggle to pay for PhD. If you don't fund PhD, nobody's going to have the time to research. So until we begin to fund PhD, you will see young Nigerians who are smart that would write research that will match on the best journal, Lancet, name them.
Ramsey, can you please round up for us? Thank you. Thank
you very much. And my last solution is just to say, train doctors in research and not just in clinical care. Most of our doctors are wired to just do clinical care. And without research, we're just wasting our time. Clinical trial today is a multi-billion-dollar area, but we're not exploring it in Nigeria. Every medication they bring from Europe and US, we pump it into our people. No clinical trial is done. Thank you very much.
Thank you very much for that wonderful presentation and also giving us pointers on what should be done. Thank you so much. They say if a tree falls in a forest and nobody's around, does it make any sound? So our next panelist, Chiamaka Okafor, will give us a glimpse of the lessons reporters covering a pandemic learned and the struggles against conflicting narratives. Chiamaka Okafor is a senior reporter, diaspora and international community for the Premium Times. Chiamaka, the floor is yours.
Good evening, everyone. My name is Chiamaka Okafor, and I work for Premium Times. So speaking on what the media or the media's role during the COVID-19 pandemic, so just two major things, on communication and then the knowledge gap for reporting the pandemic as it was really new. And I mean, there was an existing knowledge gap in health reporting, or there is an existing knowledge gap in health reporting in Nigeria, but COVID made it quite obvious and glaring. But also to commend the media that a lot of reporters, my colleagues and I, rise to the occasion and did a lot of reading. So for instance, I have no science background, but I had to take a few courses so I could report and communicate in languages people will understand. By people, I mean the average Nigerian out there. So there was that as well, but it wasn't quite widespread as the misinformation and disinformation that was out there. So it was really some knee-jerk reaction on how to counter this information. And then you needed to sit with experts epidemiologists, virologists to understand what this means and how to translate it into simple terms for the Nigerian persons. That's a little I want to share on the knowledge gap, and also to say, unfortunately, the Nigerian government officials from the health sector are no longer on this call. Dr. Damages excused them after they had spoken and they left the call. This would have been important for them to listen to, because then in all of their trainings and capacity building, they meet key stakeholders that should be involved in their trainings and capacity building, which is the media, because the media doesn't know it all, right? And so we often will learn from the experiences or from the wealth of knowledge of other persons from different sectors. And so it's important that when such trainings are happening, media persons are involved. I'm hoping that Dr. Damages will relay these messages to them. Thank you for smiling at me. And then communication. So we saw a lot of stonewalling, which was a major challenge for me. I was in communication with Dr. Sani at the time, and also Mukhtar when he took over from Dr. Ali rather. But then you saw that information wasn't coming in real time. For instance, when the 1 million doses of vaccines expired in Nigeria, it took Reuters for Nigerians to know that that amount of vaccines were in the country and had expired. And now it also brings us back to the question of what value is attached to national media or local media, if you like. So I most times would like to say that the government of Nigeria does not respect or value media in Nigeria. And so they find it very easy and it's very comfortable to rush to the likes of BBC, CNN, Al Jazeera, Reuters to talk about things that are happening in Nigeria. But when we who are operating from Nigeria make us get information for the audience we serve, you get no response. And we got a lot of that during the COVID-19 pandemic, or in the wake of it, because of course it's still here with us. And for me, that's one of the reasons that contributed to, or that gave credence to a lot of misinformation or conspiracy theories that were flying around rather during the time. But of course, there's just so much the media can do without information. We can't manufacture information. We need this information from authorities to, disseminate them. And when they don't come, we're really left with nothing to disseminate. And sometimes when you get expert opinions from the virologists or from the epidemiologists, and then you're trying to run it by the government officials, the people who take their words for it, to say, oh, is this really going on? And then they say this is not happening. For instance, again, when Omicron came into Nigeria, I was speaking with a virologist who told me this was in Nigeria already before the Nigerian government confirmed it or announced it. I wrote the story, but the Nigerian government said it wasn't true and came around, I think 1 week later or a few days after to say, oh, this is in Nigeria already. And it happened just about the same time I was trying to confirm from them. So there's the stonewalling thing, and also denying, events, things that are happening or things that were happening, and then turn around to say, oh, this is actually happening. And then it affects a lot the trust people have in government or what government has to say to them. And we see that a lot in Nigeria. The government of Nigeria has lost the trust the people should have for the government. And so when government says this, we're looking the other way, looking for alternative, responses or comments or instruction, and that shouldn't be what it is, right? So when people lose trust in government, it becomes very hard to manage situations such as what we saw during the COVID-19 pandemic. And how is this going to, or how has what happened during the COVID-19 pandemic prepared or is preparing us for the next pandemic, which is just around the corner? It probably will be the monkeypox or Lassa fever, which will go full-blown very soon because management systems are really, really very poor. And then surveillance has improved in Nigeria. Yes, I'll give it to Nigeria, but it's still, a lot needs to be done. Yes, the expiration dates for the vaccines. So the question will be, why would Nigeria accept vaccines that are soon to expire? I don't have answers to that. Mukhtar would have been the best person to respond to that, but unfortunately, he left the call. We should have options. Yeah, I mean, we have options. Staying alive is one of it. And if people had taken the expired vaccines, we would have seen the same response that we saw during the polio incident with Pfizer, and then would have become more vaccine hesitant in Nigeria. So we wouldn't want to get to that point where we say no to vaccines or things that will help us stay alive. Yeah. So I'm just going to leave that there to say that at every point, handling whatever national emergencies or national issues, the media is a key stakeholder, and every sector needs to realize that the media is a partner for democracy, for development, and for staying alive. Literally, the media is a key partner. I mean, these are a few lessons we went through or we saw during the COVID-19 pandemic, and we're also seeing that a lot has not really been learned in terms of communications on the side of the government. Things come around really late, So I think I heard Dr. Ali mention, we waiting for things to see how bad things get before we, for instance, ask for a lockdown or start to address situation. And we're seeing that with the monkeypox as well. The cases of monkeypox are popping up in different states in Nigeria, but there's not been a national emergency approach, if I might use that term, to monkeypox or how to contain it before it becomes a real national emergency. Yeah. But yeah, this is what we've learned. And even in the course of the job, some of us contracted COVID. I did contract in November 2020, and until sometime in June 2021, I wasn't feeling better. But yeah, that's it. Thank you very much for bringing me on.
Hello, my name is Chooks. I'm a COVID survivor. I was treating malaria, in quotes. I treated my first malaria, and after a while, so a couple of weeks after that, I was hit by another so-called malaria. I was having fever. I was having severe fever. I was having muscle pain, my legs, my laps. It was quite unusual. And I went back to the hospital, and they tested ran a test, and they claimed they saw some malaria parasites, So the irony is that I was one of the people that I was really afraid of this COVID. I was one of the people that actually advocated for carefulness. I was one of the people that was campaigning about the severity of this COVID. For some reason, when I went to the hospital, I just to fulfill all righteousness, I decided to do the test while I was in the hospital, that I was diagnosed for malaria. I tested for the COVID, and surprisingly and embarrassingly, I tested positive for the COVID. And that very moment that I tested positive to it, the hospital had to send me away. I was asked to go to an isolation center, and I had this phobia for those isolation centers. So I had two options. So I just go to the isolation center, or just go home and isolate myself and take all the medicine. It wasn't a pleasant experience, to be honest. I heard about the symptoms of the COVID, and I always told my friends, I used to joke about it, and I told my friends that, do you know that we might have gotten this COVID? We might have tested positive to this COVID one way or the other, but we didn't know because we are asymptomatic. But this time around, I was symptomatic. And when I sleep, I was having some kind of hallucinations. I was having severe fever that I couldn't explain. Most times it's either I'm extremely cold or extremely hot at the same time. It was a confusing state of mind. It's not an experience anybody would want to have. At another point, it got to a point that I couldn't smell anything. Like, I would practically take my perfume, and I spray it Like I'll spray it in my nose and go close. I couldn't perceive. In fact, I got to a point. I was like, no, this is not COVID. No, this thing I hear about cannot be happening. I had to spray it here. I'm not kidding. I had to spray it on my mustache just to make sure that it gets through my nostril. When I sprayed it, my brother, I couldn't perceive anything. So we will not really get the fact that COVID is real, but we shouldn't be. So I know we shouldn't be too afraid of it, like to the extent that you harm yourself trying to be afraid of it. But it is real, and you have to actually protect yourself. Be careful. One of the easiest ways to protect yourself is to always wear a mask and to move around with sanitizer. It helps. And wash your hand regularly. Avoid a crowded place. And if you're talking to somebody that you suspect might be having COVID, just distance yourself. I'm not saying that you should be suspecting it, but just play your part, please. Cover yourself, cover your nose, wear masks, a good mask. Protect yourself. COVID is real. Once again, my name is Chuksi, and I'm a COVID survivor.
Thank you, Chiamaka. Thank you so much for that contribution. And let me also say that I did not excuse anybody. People had other engagements, and I have to acknowledge that and accommodate them. I can force people to stay, So having said that, I said that we are going to have an opportunity to pass across some of this outcome of this conversation to all the officials. We have one last person before we take questions for the second panel and even the people who are still left from the first. We have my co-moderator, Dr. Chisom, to give us his take. He's a physician and research scientist here in New York. And he will talk about, I forgot what we were going to talk about.
That's okay.
But you know what you're talking about.
Yes.
Go ahead.
I won't belabor the points that have already been mentioned. I'm a physician here in New York, and I'm an internist physician, still in training, with hopes of specializing in critical care, ICU, in critical care, which is very important, obviously, in COVID. Dr. Dama just wanted me to talk about the physician in pandemic times and the lessons for Nigeria, right? So I'm going to talk from my limited experience, and hopefully, I'm sure some of the other doctors on this panel probably have different experiences. I only have experience from what people told me in Nigeria, so I'm going to talk mostly about what I saw here in the US. So, quick points. Data collection is extremely important. It is extremely important. That is something that a lot of us here fostered and made sure that the government was doing. I wouldn't go into the politics of what happens in the US and how certain people of certain political leanings did not want data collection. But at the end of the day, because of how robust the healthcare system is and the level of scientific acumen that is here, a lot of the healthcare professionals prevailed over the politicians, and data collection continued. Because guess what? You can't address a problem unless you have data to support that it's happening, right? So you need to be collecting data, knowing who has COVID, how many test kits are available, what are the public health infrastructures and logistics that are in place, what is the current issue at hand? Is it that we have less vaccine, or is it that we have more and we have less ways of being able to disseminate them? For example, the vaccines that we got, from the information that I know, whether or not I'm not sure if it has been verified at this point. What I know from looking at the news and some of the reports were that the vaccines were about to expire. There's nothing wrong in getting a vaccine that maybe is going to expire in 2 months or 3 months. Now, the key is when you accept that vaccine, do you have the logistics and the capability to be able to mobilize people and resources and get people vaccinated? Because guess what? If you allow those vaccines to be in the country and they all expire, and you haven't put out a message to tell people, oh, by the way, we got these vaccines, but we weren't able to mobilize and get it quickly into people's hands, therefore we're going to destroy them. What happens is when people find out later on, one, you've lost your credibility. People won't trust you anymore. So when you talk about vaccine, there's going to be incredible hesitancy. And so it kind of destroys the message that physicians are trying to get across. So data collection is important. Public health education is very, very important. As a child growing up in Eastern Nigeria, I remember getting vaccines in school, and there was a little bit of education. I know with the polio issue, I think Nigeria and Pakistan were, either Pakistan or Afghanistan were the two countries or three countries where there were still a little bit of polio left. To what extent Nigeria was able to mobilize the public health infrastructure and educate people, especially in northern part of the country, to combat vaccine hesitancy, I am not aware of. But it kind of tells us how important public health education is, because if we're able to educate people who may have believe in different conspiracy theories, or who may have some cultural or religious mindset that may prevent them from getting vaccine, if we're able to do good public health education, we shouldn't have polio, still have polio in Nigeria at all. That's just an example that I'm trying to give. And the third thing is, I know that most of people, large percentage of people who are affected by COVID are those who are much older, the elderly, people who have comorbidities, so hypertension, high blood pressure, diabetes, and heart disease, and things of that sort. And I think where Nigeria may have escaped a little bit is that we have a larger, younger population who coincidentally tend to have less of those issues. And so if you have a country where you have a large percentage of the population are older, and being old, a lot of them already have these comorbidities, as we call them, it exposes them to being severely suffering severe consequences or disease when they get COVID. Now, it doesn't mean that we cannot be transmitted to people who are younger. It just means that if someone who is younger has those, gets COVID or doesn't have those comorbidities, there's less of a disease state. But one thing I want to caution us about is non-communicable diseases like hypertension, diabetes are creeping up in what we used to call what we call third world countries. In places like Nigeria, we're seeing high rates of hypertension in younger populations, we're seeing diabetes. So let us not feel that we are immune to a pandemic such as COVID, even though we may have escaped bearing the brunt of it compared to countries like the US that has a larger population of older population. I want us to hold our public health folks accountable and our physicians accountable to make sure that we're looking into younger populations and making sure that diseases that we didn't used to see in younger folks are being well managed. I can talk about instances of receiving text messages about of people who have passed away in Nigeria, younger people in their middle ages, and it's always an issue of if someone had a heart attack or someone's had diabetes, wasn't well managed. So there are comorbidities that we should address, which we know from studies causes you to have severe consequences when you have COVID. So 3 points: data collection, robust public health education, with messaging that is very clear and concise to make sure that our credibility is not lost, and making sure that comorbidities are addressed and there is good communication about the risk factors. Some of what I have seen being done by colleagues back home, I've seen people who have been doing health fairs, educating people about managing their blood pressure, doing blood pressure checks, and educating people about sugars, and making sure that people are eating well. One thing that I know is, even though we have a very high starchy diet in countries like Nigeria, there's a high level of physical activity. But as we transition from people moving from rural population, where people are more active and farming, to the urban centers where there's more sedentary life, all those comorbidities, people are less active, it increases, and we're now eating foods from fast foods and things of that sort. So comorbidities are definitely important in terms of messaging by physicians, especially physicians who are in the primary care field and in the healthcare and in the public health field. I'll just stop it there.
All right. Thank you so much, Dr. Chisom. We are going to take questions now, and anybody who wants to ask a question, we raise your hand. I know, Kayode, you've been trying to ask a question. You go first.
Okay. Thank you so much. Good afternoon. Am I audible?
Yes, we can hear you.
Thank you so much. My name is Kayode Toriola. So I'm a banker and also a media personality here in Houston, Texas. I want to appreciate all the speakers and contributors to this seminar or public show. It has been quite rewarding and useful in our search for solutions to myriads of problems in Nigeria. Yeah, before I ask my question, I will make a little contribution. And I want to make reference to Professor Udoka's assertion. I want to thank Professor Nwosu Udoka for setting the record straight in terms of asking pertinent questions. Unfortunately, the Nigerian representatives, as far as this show is concerned, are no longer here. But just like I think the media or the Premium Times lady or somebody else said, Dr. Damages is here to relay our message to them because we still want answers from them on some pertinent questions. You know, the problem we have as a country in our response to COVID-19 is just that we lack credibility, we lack data, we fail to use the resources that we have. I will not say we lack resources because we have them, but we don't use them. And also, we expose our people to a lot of troubles because of our lack of seriousness in handling issues. Professor Nwosu has a question that why is it that the Minister of Health will not take it as a very important activity or responsibility to visit, college hospitals? Nobody was able to answer that question the way I expected a serious person will answer that question. They only perambulated or paraphrased it. I remember Mukhtar answering that question, saying that he met Minister of Education and Minister of Health at a function recently, doing or holding meeting with some stakeholders. How has that one, how is it the same as visiting colleges of health to know what is happening on the ground, which will enable him to find lasting solutions to those problems of this COVID-19? It's very unfortunate. Another thing is that he also made reference to the fact that there was no data availability. And if you don't have data, how will you solve problem on ground? Because you need to know the number of people that are affected, even the numbers of people that are affected with this COVID-19, number of people that have been tested, number of people that have died. We don't have accurate data. So how will you now prevent recurrence of future problems? Now, as a banker, I now want to ask question about palliative. During COVID-19, and I believe Dr. Damages will note this down, I also sent it to them. Though they are not here, they must answer some of these questions and let us know what they are doing, because we are also affected in one way or the other. The question is, the money voted for palliatives, if we all remember or we can recall, there was an instance that the rice or groundnut oil and some materials bought that were supposed to be distributed to people were, hoarded or were being taken over by some individuals. And it was found in an area around Abule Egba or Yanopaja last year. I believe some of us can still remember. What is the result, or what is the effect of that discovery? What did the government do to those people that did that thing? Because these are the issues. When people are having COVID, they cannot go to work. Are they not going to eat? Are they not going to pay rent? Are they not going to pay school fees? So these are the pertinent questions that I think these people still need to answer. And without wasting much time, I still want to thank all the participants here today for taking their time to attend this show, and equally appreciate Dr. Damages for all the great things you are doing. I know a lot of resources go into this. This is what the government is supposed to be doing, honestly. But because we are not focused, we are not proactive, and we are not thinking on how we can better the loss of our people. Our leaders are so selfish and inordinate, only just to please their pockets. That's why people are dying like chickens every day. All they are interested in now is 2023 elections. And just like Dr. Ngozi said, COVID is still much around, whether we like it or not. The earlier we realize it, the better. I was speaking with one colleague yesterday, and I learned that between April, this is a nurse who came to my office to transfer business in my office yesterday. He said COVID has started rising between end of April and now, astronomically. So the earlier Nigerian government realizes that, the better. We are only fortunate in Nigeria because of our environment, or maybe it is cultural. I don't know. That despite that the people are not even following all these COVID-19 protocols, there are still less or fewer deaths. We are just lucky, but we should not trivialize it or treat it with levity, because the consequences may be very, very detrimental. Thank you so much, and I appreciate the opportunity.
All right, thank you, Kaede. Thank you so much for that wonderful contribution. I don't know if anybody in any of the panels, Professor Nwosu, do you want to weigh in? I had your name mentioned several times.
Thank you, everyone. And I must say, I didn't know what to expect coming into this session, but I'm glad that I have learned a lot from people, so that's good. Yeah, the next question is, where do you go from here? In Nigeria, there is no continuity. Now we've done this one. Are you going to do something next? Are you going to get the health minister to come on your show? I know it will take a lot, but it's possible.
Yeah,
so he can answer our questions. I mean, we're not afraid of whoever. We will speak to power. We will speak for the youth. We will speak for our people, So thank you for this.
All right, thank you. I want to say that on my own behalf, I will try to get Mukhtar to come back on the other show, maybe 90 Minutes Africa, and then that's more interactive. This was supposed to be just a conference, people speaking from different angles, but I can see that there are a lot of questions for the government side to answer. So I will reach out to him. Remarks? Yeah, go ahead.
Yeah, just a few remarks because I have to get back to work. But I just wanted to, just as a public service announcement, because obviously people are gonna listen to the recording of this later on. I don't know how many people are watching this online. One thing I want us to, which is, this is kind of borders on public health messaging and how physicians communicate about COVID and vaccination to delay people. One thing I want to make point across is this: I'm going to make it very simple. When it comes to immunity, the way I see, there are two types of immunity. There's one that you're making antibodies, right? The antibodies are there to prevent, infection from getting into your cells and getting into your body, for lack of a better word. The second thing is optimizing your body so that if, for example, the infection crosses that protective barrier and gets into your system and you start having disease, that your body is able to recover quickly. What we found with vaccination, with the vaccine, and other healthcare professionals, please chime in and correct me if I make a mistake, is that even though its efficacy is not 100%, maybe it's 90%, 80%, for example, and you become sick, that optimization, which is the second part of the immune system, which is the T cells, that optimization has already been done with vaccination. And so even though you may become sick, you may not become very severely sick. So if, for example, you would have spent 10 or 12 days in the hospital, you spend 5 days in the hospital, or you don't even spend time in the hospital. If you are going to have shortness of breath or severe consequences, it may just feel like it's a regular flu, right? So it's important that we keep this message simple and put this message across to people so that even now that things may seem to be dying down, that people get vaccinated. The second point I wanted to make is the importance of data collection. Yes, that most of the early symptoms that we see and the main symptom is shortness of breath, but there are people who are having COVID symptoms that we are not used to. What we found out from research and from clinical guidance and some of the anecdotes is that COVID is a thrombotic disease as well. So when someone has COVID, there's increased risk of that person having clots, whether it's clots in the lungs, like one of one of the panelists who had COVID mentioned. And so people may be having other things happening. Someone may have a heart attack in their village, somewhere in the east or in the west, but you don't know that it was because of COVID because you didn't test that person. That person was COVID positive, didn't have any lung issues, but had clots, maybe clots in the leg or clots in the brain, right? Or had a gastrointestinal issues, which lead to maybe dehydration, electrolyte imbalance, and the person, became, confused and eventually passed away. So that's the importance of data collection. So that when people are sick, they get tested for COVID. So we can be able to correlate, okay, is this because of COVID or is this maybe some other independent issue, right? And in terms of monkeypox, I think the lessons of COVID should tell us that we should start putting things in place, right? Here I am in New York. Our monkeypox cases weren't even that much as of 2 weeks ago, but we're already taking precautions. I've treated at least one monkeypox patient, and we were very, very careful in how we handled the patient. Even when we didn't have enough data in terms of transmissibility and how infectious it is, we were extremely careful in how we operated. Data were being reported. People who were exposed were being notified, and things of that sort. And that's something that's missing in Nigeria. So you have to have contingencies in place so that you don't wait for you to have a huge pandemic and you are struggling trying to find ways to handle it. Right? So that's all I wanted to say.
All right, thank you. Dr. Gwane.
Hi, everyone. I must say that I really enjoyed this forum. I wasn't really expecting to enjoy it this much, but I did. So, and I must reiterate, we need to get the government officials here. We need to speak to them. They need to, because this is actually the bulk of this rests on their table. We can talk from today to tomorrow of what we experience here, but the truth is we are actually trying to channel something positive to the people in Nigeria who are actually they're not getting the best out of whatever is available. So now we're talking about the data collection. We know definitely that we do not have enough data. What do we have in place? How do we generate our data? Can we even account for the deaths and births in Nigeria? Let's start from the basic. Can we account for that? Let's start from there. Maybe that's the first start. Then we can come up the ladder. Now, vaccines, we want to encourage them to talk to people about taking vaccines. How about people get out there and get vaccinated and they're worse off for it because they didn't know that they didn't get a viable vaccine. So what is our culture? What the culture change system? What is it like in Nigeria? We know about the light issues, the NEPA, in quote. So how are these vaccines being stored? Let's start from storage before we talk about dissemination. Even the test kits that are available, they still have expiration dates. How do we know that people are being tested with kits that are viable? So what data are they giving us? They have paper, and what data are they giving us? Where did they bring all that from? Publications here, from what? So that's where I'm coming from. We need to get to the grassroots and we need to tell ourselves the truth. They are not being totally honest. There's a lot of things amiss. And when we get all these things in place, now we can comfortably start researching. We have a lot of bright minds in Nigeria. Now we can now create our own. Now somebody was talking about Lassa fever being in. Yes, when I was teaching in National Hospital Abuja, yes, I saw cases of Lassa fever. I know what it was like, and we know how the healthcare professional. Oh my God, a nurse had Lassa fever. Nobody wanted to pass her medication. That's the nurse that works in National Hospital. Nobody does this. They are all being careful. Cholera has killed medical practitioners in Nigeria. Just cholera. So what are we doing in our country? That is just the truth. We need to go down to the grassroots. And the honest truth is that the government, there's monopoly of the healthcare sector and for everything. So we can't really do much without going to them. So we still have to come back to them and say, hey, can you please make the level the playing field so that people can come out. There are people outside the country who would want to chime in, who want to bring a lot of things down to Nigeria to help the average Nigerian. But no, and I still want Dr. Damages. Dr. Mukhtar still has to answer that question regarding the J&J vaccine, because they need to tell us how they are screening the people, how they are actually screening the people to prevent this. Because the truth is that the side effects are there. So there are people like here, you can say, you want to recommend this to a patient, and you say, oh, the risk factors. You have the risk factors that are applicable for thrombocytopenia. So you're not a good candidate for J&J. So why don't you go ahead and get Moderna, or go ahead and get Pfizer? Now for the Moderna, we've known that there's this cardiovascular involvement. So we see that this is the case. We say, okay, why don't we go ahead and get Pfizer? So why are we pushing down J&J, and we're not even trying to know who is a risk of this event? And we are trying to, he said it's small. No, it is not small. 1 in 100,000 is not small. So when he used that word small, I was like, okay. I thought he would stay around for a bit, so that he will understand what the statistics and the data, the numbers. The 1 in 100,000, it's not small. So rounding up, we definitely need a region, and we need to have them on board, and they need to answer the serious questions.
All right. Thank
you. Thank you, everyone.
Thank you so much. Is there any other person who has a question or comment?
I have one last point.
Okay, go ahead.
Because I was seeing a lot of comments in the chat, and I don't want to belabor the point of a vaccination and the science of it, but the mistake that people make is people think, okay, so let me give you an example. If there's a difference between 70% or 80% of Nigeria being vaccinated within 1 month versus you achieving that 70-80% in 1 year. And the important thing to take note of here is considering that the vaccine are not 100% efficacious, and also that the immunity that the vaccine confers starts to diminish at some point. So therefore, when you look at a snapshot of the first day that you start vaccination to a year after, yes, you may have 70% on the books, but at that current point of that 1 year mark, how many people's vaccination immunity are still active? So even though you may have 70% vaccinated, you may only be about 20% whose vaccination are still effective. And so when you're looking at herd immunity, right, and you want to achieve herd immunity of about 70-80%, you actually have not achieved herd immunity. On the books, you have 70% vaccinated, but in reality, you only have about 30%, and you still have not reached herd immunity. And so the issue that people see in countries that have high vaccination, and you're asking, oh, this country has a high vaccination, but why don't they have increased immunity and less COVID cases compared to places that don't have a vaccination? You have to consider this perspective as well. For example, in the US, if many people were vaccinated within the first 2-3 months, and we achieved that very high percentage, we would have achieved herd immunity and had less cases. But the issue was there were a lot of issues with messaging, logistics about putting things in place to get the vaccine to everybody. And so you can't really make that argument of, oh, this country has a high vaccination rate, therefore they should have less cases. That's my last point.
All right, thank you so much. Any other person, any other comments?
One last comment. The reporter, I don't know why she's still around, but she said something about the government not listening to them. If she can actually write a piece on those questions that the government officials were not able to address, I think they will listen to her.
That's a good point. I believe that there are other reporters who are watching and who will write stories based on the conversations that we have today. On that note, I want to thank everybody that joined us today. I want to thank Dr. Sani Aliu, Dr. Mukhtar Mohammed, Professor Benjamin Wosu, Dr. John Ndibe, Dr. Ngozi Obiwane, Dr. Chisom Okezue, Mr. Ronsi Chidebe, Chiamaka Okafor, Austin Okwesile, Stella and Chooks, and Humble Prince. I thank you all. I want to also thank Paul Adeyeye, my project manager at the Open Society Initiative for West Africa, for his support and patience with me. and of course, all those in the organization who gave this opportunity to me. I also want to thank those behind the scene who helped to make this possible. My advisors, Chido Onuma, Oken Dibe, my technical people, Ola and Professor Ajibola. And I take responsibility for what didn't go well as planned. It was perfect on paper. Seriously, it was very perfect on paper. It didn't start well, but thank you all for spending the time with me and your evening on Saturday. I promise you that in days to come, we are going to locate the government officials and we are going to get them to answer more questions as you guys have demanded. On behalf of everybody, once again, thank you and hope to see you next time I call on you. Really, I appreciate it. It's not everybody that you call and they will help you, especially African Queen, Dr. Obiwande. I really appreciate you stepping up and helping me a lot. And of course, my Dr. Dominic. Thank you so much, everybody. And hopefully we will do this again in no distant time. We do this and get the government officials to answer the questions that everybody is interested in. Okay. And on that basis, I say thank you and see you next time.
If you have an opportunity to get the COVID-19 vaccine, please do. If you don't want to, don't take it. Nobody will force you to. But please don't waste your time listening to all the nonsense conspiracy theorists are spewing all over the internet. If white people want to kill us, if they want to kill us all, they do not need to do it through a vaccine. They will get it done using Hennessy. If you don't drink Hennessy, they will put it inside geisha. If you don't eat geisha, they will put it inside Italian shoe that you wear. If you don't wear Italian shoes, they will send a drone as tiny as a mosquito. Yes, they have those drones. They will fly over the skies of Africa and Nigeria and release small doses of radiation or radiative substances that will wipe out any number of people they want. In fact, they can decide to wipe out those born on Monday or born on Tuesday or born on Friday or those of certain heights. Whatever they want, they have the technology to do it. And there is nothing you can do about it. We should stop humoring ourselves that we are so important or so capable of surviving any attack. A people that do not make medicine that they take, food that they eat, drinks that they consume, the clothes that they wear, the car that they drive, the Holy Communion bread and wine that they take each Sunday, should just be thankful every day that those who make those things are not evil. Every 30 seconds, malaria kills one child in Africa. Every day, about 3,000 children die of malaria in Africa. Every year, almost 1 million. We Africans have not been able to do anything to save those children. In the last 50 years, we have lost 50 million kids who will have grown up to contribute to Africa. They will have married and had their own kids. If they had 3 kids each, on average, they will have added 150 million people to Africa's population. We are still waiting for some evil, quote unquote, white people to develop a vaccine for malaria. In the meantime, we spend hundreds of millions of dollars each year paying the same white people to make malaria medicine for us to take just to be alive. Every African should just be ashamed of himself or herself. Without those white people who make things that keep us alive today, diseases, famine, or natural disasters will have wiped us out. And it is not that we don't have the brain to make things for ourselves, but we prefer to waste our time, our lives, chasing shadows, pointing at people trying to stop us, people trying to kill us, or trying to make us look bad. We are absolutely useless if you actually think about it. We carry our lazy selves around praying to God and waiting for God to save us. We are probably the greatest disappointment to God. For he gave us the same things he gave to the white people, the Chinese, the Indians, and co. But every day we run to churches and mosques looking for solutions to problems. Meanwhile, we have all that it takes to solve the problems. I'm mad by how quick we default to hopelessness and this feeling that they are out to get us. Any day they want to get us, they will do it while we are sleeping. I'm so sorry. One of these conspiracy theory videos someone sent to me just annoyed me. The man in the video is well-fed American and well taken care of. We should not help him spread that nonsense he's talking about. Coronavirus is so stubborn that we need to remain cautious and vigilant. Okay, look.
I will take it.
I don't think I'm going to be vaccinated. I will take it.
I'm not going to accept the vaccine. It's going to keep us healthy. Why not?
I will take it. I cannot take it.
Yeah, different people, different views. One woman asked an important question. Watch.
We've been seeing different reactions about the vaccine online on social media. People doing some funny dance moves. Would that really happen? I don't want to have like a negative reaction to the vaccine. I don't want to be all those things that is going on.
Well, Dr. Damages took the vaccine last week. I'm here and I'm doing what I do well. Run my mouth. Hear the woman again.
So if it's going to be positive, why not? If it's going to keep us healthy, why not? I don't really believe that it's 666, as people say.
So I hope you will take the vaccine when you get the opportunity. In the meantime, still well. Now, at the United Nations, going on right now, the Secretary General lashed out at rich countries for not doing enough to help poor countries deal with COVID-19. Listen to the man.
On the one hand, we see the vaccines developed in record time, a victory of science and human ingenuity, surplus in some countries, empty shelves in others.
Yes, victory of science ended up as surplus in some countries and empty shelves in others. They're very pathetic. Watch the man.
This is a moral indictment of the state of our world. It is an obscenity. We passed the science test, but we are getting an F in ethics.
Yes, we passed the science test, but we are getting an F in ethics. Now the Secretary General so shamed the world that President Joe Biden of the United States announced that the US will be donating another 1 billion doses of Pfizer vaccine to poor countries. You see, this is what I'm telling you. Coronavirus is so stubborn. Today, we sent our crack reporters to Ihala to speak to native doctors. Yeah, we are breaking new grounds. Yeah, we wanted to know how they are surviving this pandemic. Watch.
Imana Merine Jesu Sikano Maya Umazum Yatia Yobuna Wasu men unu make him.
What I called it?
Oga no Nima Kahograga. Adasina Kurabina. Aside Bushibon, I will hear Wabaka. Iwaka Meguma and Dinana like Iwaka. Moromo is the name of the man, Purano.
We also asked them what they feared most during this time of COVID. Native doctors, listen to them.
No, I want you to
Guinea code you have to go.
You're the two job on an amateur. On Catrawa come on your first senasa. As it to be able because I didn't feel about the coronavirus. Now, I got the two of you, I can't do one of them to hear what you with me. I have one of no, I don't know Granny Bushy, Magina, or an FF. I have about the coronavirus, about my home. So I cannot go and use something and cover my nose because of coronavirus. No, them. Okay. I want around my area, around my house on them as well.
And the most important question, if they would take COVID-19 vaccine, if it were made available to them, pastors will not take it. Would they take it? Watch.
Hey, man, I don't know when I come my honey. I'm walking down with them. So now, before I ban him up with 2 here, mma jụrụ ndị mmiri ha so ajụjụ maka ntọ na-aba m n'ahụ ntụtụ.
Okay, okay.
I will not agree.
Maka gịnị?
Because I don't know the vaccine. I'm not in, I hear about coronavirus, but I've never perceived anything in my body about coronavirus. So I will not take the vaccine because I don't know the income of it or the after effect of that.
See, coronavirus is so stubborn that we need to remain cautious, all of us. In the meantime, wear your mask, wash your hands, maintain social distance, follow health officials' guidelines, and stay safe.